Hi everybody and welcome to PCR London Valves 2025. My name is Francesco Maisano and I'm here with a good friend, an expert in tricuspid, co-director with me of the tricuspid focus group. But today Fabien Praz is with us as the chair of the guidelines. So Fabien, new guidelines, always difficult to build some guidance with evidence. But also very important. So can you please tell us now how these guidelines are going to impact our practice, your practice as a physician?
Yeah, thank you very much, Francesco, for the question and for having me on this topic. Obviously, tricuspid is a very important topic. We have expanded a lot the chapter in the guidelines, and we focused first on the first step for the patient with tricuspid regurgitation, which is workup. And you know, and we learned also during the last year that the workup for this patient is complex, and it needs to be done by expert center in a multidisciplinary way, including right heart catheterization, of course, including imaging, advanced imaging, to diagnose TR, grade the severity, but also look at the mechanism. And finally, you need to involve your colleague in the management of this patient, including electrophysiologists for patients having pacemaker or having atrial fibrillation. So there is a lot of emphasis on the diagnosis and the multidisciplinary workup of this patient, which is complex.
There has been also something which has been a little bit changed in the surgical management of patients. Can you summarize a little bit what is changing in surgery specifically?
You know, surgery still plays a very important role for tricuspid patients. It's not done enough, and these patients are not referred enough for surgical treatment. But in particular, in patients with concomitant valve disease, mitral and tricuspid, or operated for aortic valve disease or CABG, you need to look at the tricuspid regurgitation when operating on this patient. And this is still the case. So the concomitant repair of tricuspid regurgitation is very important. But what has been adapted a little bit based on randomized controlled trial is the indication. So we now recommend repair for patients with moderate or severe tricuspid regurgitation. It still may be considered for patients with mild, but with a lower class of recommendation, because there is a risk, there is a price to pay as well, which is pacemaker. Pacemaker rate were about 14% in this patient. So we emphasize the selection, the correct selection of this patient having concomitant treatment.
And finally, obviously, what everybody is looking for is now higher class of indication for transcatheter interventions. So what is happening? Repair, replacement, is there a difference?
Yeah, so we had a fantastic development during the 4 years between the two guidelines in terms of evidence, with randomized controlled trial on transcatheter replacement and repair, showing about the same improvement, huge improvement of quality of life in this patient. And that's why we have now a 2A recommendation for this treatment. Difference between repair and replacement are not yet in the recommendation because we need to learn more. But obviously with repair you have a very safe procedure that do not manage to have a reduction to mild TR in all patients. Replacement is very effective at reducing TR, but with some risk of complication, bleeding and pacemaker. So a huge development, I think, for minimal invasive treatment of this patient that were not treated before.
So if I can summarize for us who are reading and applying the guidelines, probably I think number one, what I learned from, and I'm very happy to see clear statements about the network, establish a network of care for these multimorbid and complex patients is the number one. So the workup of a patient is fundamental. Second, surgery is still playing a role in a multidisciplinary approach. And finally, and very importantly, a very high level of evidence for a class 2A indication for transcatheter interventions, specifically to improve quality of life, to induce reverse remodeling. Yes. This is the exact wording that you applied. Absolutely. Because still there is no clear evidence about survival, if I understand. But very important, there is strong evidence supporting these therapies, and still a lot of questions to be answered in the future. PCR Tricuspid Focus Group goes forward to try to help us in these gray zones, but thank you very much for implementing guidelines and to help the community to go forward and apply the best possible practice for our patients. Stay tuned for more.
Thank you, Francesco.